A patient with a history of spinal cord injury at T6 or higher and has severe hypertension and pounding headache. What is your initial impressions? Hello there, I'm the nursing student Avenger and I'm going to be your NCLEX tutor. So today let's talk about autonomic, I'm underlying the autonomic dysreflexia. Now, for NCLEX, I want you to remember this. The blood pressure is up and the trigger is usually below the injury. So autonomic dysreflexia usually happens to patients with spinal cord injury at least T6 or higher. So anything higher than T6. So what does it mean? So injury in T5, T4, T3, and so on are going, and cervical, of course, are going to be under this impression or diagnosis. So what exactly is happening with autonomic dysreflexia? So think about this, y'all. The body gets triggered by something below the injury, but the brain cannot control the response correctly. So the triggers, as you could see over here, and let me focus it on the screen, the triggers are usually below the injury. So remember, the injury is T6 or higher. And so what happens is the patient gets this sudden, dangerous rise in blood pressure. We're going to talk more about that. This is not just a regular high blood pressure. Y'all, this is a medical emergency. Now, let's talk about the triggers again. So let's go through it one at a time. So the first one, right? The most common trigger is bladder, and usually bladder distension, or there is a kink in the Foley catheter. That's why the urine is backing up into the bladder. So think bladder distension and sometimes a blocked urinary catheter. Now, what are the other triggers? So that's the first trigger. That's the most common. So that's usually the first thing you're going to assess. What are the other triggers? Bowel impaction, tight clothings is another trigger. Pressure injury or anything irritating below the spinal cord injury. So when NCLEX gives you autonomic dysreflexia, do not think of medications first because that's our impression, right? The high blood pressure, the pounding headache. Do not think about that. Now, what does the patient look like? The biggest clue that you're going to see with these patients, the first one really, this is dangerously high. This is what we call severe hypertension. The blood pressure is not like 180 over 90 or something like that. The diastolics are on the hundreds as well. Okay, so they have severe hypertension. What else? They're also gonna have, the presentation is gonna have pounding headache. Bradycardia can happen, y'all, and then flushing and sweating. So the flushing and sweating is usually above the injury. So it's going to be in the face. And then below the injury, you're going to see pale and cool skin to touch below the injury. You're also going to have nasal congestion. So I'm going to point this out. This nasal congestion is really very cardiovascular in nature. That hypertension is causing that nasal congestion. Of course, blurred vision comes into play and anxiety. So again, remember this if NCLEX is going to ask this in your question. A spinal cord injury, really higher than T6, a high blood pressure, very, very high blood pressure, I should say, pounding headache and sweating, think autonomic dysreflexia. Now, here is where NCLEX really cares. this one over, let me focus that on the screen, this one over here, the priority actions. Okay, so what do you do first? Boom shakalaka, this one, right? The first action is to sit the patient upright, high Fowler's position, and raise the head of the bed. Now, why are we doing that? The sitting position alone helps lower the blood pressure and decreases the risk of stroke. So this one decreases the blood pressure. Now, not significantly, of course, but it can lower it down. And at the same time, it decreases the risk of stroke. Okay? Sorry about my dinghy there. Now, do not leave this patient. Very, very much. Do not leave this patient. At the same time, I just want to point this out here that we don't want to put the patient on a flat supine position. The main thing is we're really going to figure out what's causing this problem. Like I said, the first common one is bladder. Now, after the positioning or the loosening of the clothing and constrictive devices or anything, the next thing you do is we're going to first check the bladder. That's the first thing we need to do. Check the bladder, looked for kink catheter, checked if the drainage is full or the drainage bag is full, assess for urinary retention, and if there is an order to catheterize the patient, see if you can catheterize the patient. Now, why are we looking at the bladder first? Because the bladder distension is the common trigger. Now, if the bladder is not the cause, then we check. The next thing we're going to do is check for bowel impaction, right? Check for bowel impaction. We also need to monitor blood pressure frequently. Well, hello, the blood pressure is very, very high. So we need to check it as frequent as possible. And then if symptoms continue or the blood pressure still stays really high, an antihypertensive medication is usually ordered. Remember this. The key is to find, let me underline that, to find, you can see that on the screen right now, to find and remove the trigger. Okay, so I usually try to wrap it up and do it again for emphasis so that we don't forget anything of what we talked about. Okay, so the first thing is remember that autonomic dysreflexia is a spinal cord injury, usually a T6 or higher. The patient is usually going to have severe hypertension. Okay, so let's focus on this screen over here. The trigger is usually the bladder. Your first nursing action is to sit the patient upright, and we talked about the rational. Then we tend to loosen the clothing, check the bladder, check the bowel for impaction, monitor blood pressure, and remove the cause. So always remember this NCLEX Pearl that I'm providing here for everybody. So as a recap, T6 and higher, the trigger is below the injury. Hypertension is usually the main thing, and pounding headache. And this priority is sitting the patient upright. So I hope, I'm going to circle all of this. I hope that this tutorial on autonomic dysreflexia is going to stick. And if this question shows up in your exam, you will confidently know the correct answer. So if you like contents like this, if you don't mind, subscribe to the channel because I'm going to be creating a lot of contents right now in YouTube.